So next we have Dr. Vidhya Verma presenting us some diagnostic dilemmas in necrotizing scleritis.
Yes. Good morning, everyone. Here I am presenting diagnostic dilemmas and therapeutic challenges in infectious necrotizing scleritis. As we know, the most severe and obstructive form of the scleritis characterized by ischemia and necrosis of the scleral tissue. It presents as the acute onset, localized pain, purulent discharge and conjunctival defect, progressive scleral thinning. Delay in diagnosis and treatment can lead to the globe perforation and the permanent vision loss. Prevalence of infectious necrotizing scleritis occur for approximately 5 to 10% of all scleritis. So we should suspect infectious when if there is a history of recent ocular surgery or trauma or immunocompromised conditions. Bacterial is common, fungal is and viral is rare. We should suspect autoimmune necrotizing scleritis when there is a autoimmune systemic history, bilateral multiple involvement and history of the similar episode. So there are few unusual presentation of unusual scleritis. Necrotizing scleritis is rare and infectious necrotizing scleritis is rarest. So this series highlights how clinical vigilance and microbiological precision saved vision in high risk patients. This is the case one where there is a 45-year-old man presented with delayed onset scleritis after vegetative trauma and gray-white scleral thinning we can see in this picture with the overlying conjunctival defect of the necrotic tissue and adjacent abscess or purulent multiple foci are present there. So, when surgical debridement in necrotizing infectious scleritis and microbiological evaluation should be done. So, case underwent and targeted antimicrobial therapy based on the microbiological finding were started. That was antifungal, and the fungal cases required multiple surgical debridement, and steroid were introduced cautiously post-infection control. So these are prompt diagnosis, microbiological workup and targeted therapy are crucial with early surgical intervention considered in fungal cases especially. So we can see this picture, and despite treatment there is a residual scleral thinning and visual impairment remain. So this is the case too where there is a 58-year male and 2-month post-cataract surgery. There is a severe pain, localized scleral thinning and necrosis and the superior limb cervical site with the rapid progression surrounding the congestion and corneal infiltrate. B-scan there was no vitreous involvement and initial steroid worsened the condition. So in microbiological evaluation we find Pseudomonas aeruginosa growth, and there is a management with the targeted topical and systemic antibiotic and surgical debridement. Outcome was the vision preserved at 6/18. So literature also suggests the improved outcome with the combined medical surgical approach for infectious necrotizing scleritis, particularly for the fungal cases which have traditionally poor prognosis. So we should differentiate infectious and non-infectious. We should take history of surgery and trauma, purulent discharge and poor steroid response, microbiological confirmation essential to diagnose infectious. So we should always rule out non-infectious with the autoimmune markers and inflammatory markers, chest X-ray, CT and HLA typing. Imaging should be done to B-scan ultrasonography to evaluate depth of the scleral thinning and anterior segment OCT to differentiate abscess from the scleritis necrosis and UVM for the posterior segment involvements. We should differentiate it as infectious is deteriorate very rapidly, and there is improve with targeted therapy often required debridement and grafting and 5-7 days with the appropriate entomicrobials. So we should follow algorithm of management. And we should also consider multiple spacing type like the swab, scraping, biopsy to make diagnosis. So take home message is rule out infectious infection before steroids. Microbiology is your compass, and surgical debridement save the globe. INS is rare but devastating if missed, and critical warning immunosuppression in undiagnosed infectious scleritis can lead to rapid perforation of endophthalmitis. So best practice always rule out infection through culture or PCR before starting systemic immunosuppression. Thank you.
Can you play this presentation again? Come to the treatment modalities for the slide. Next. The treatment options, management options. This.
This?
Next,
One slide
next.
before.
Okay. No, the penultimate slide, the last but one slide. Second last slide. Okay. So what will be your, way to go? Because sometimes these patients present to you in an acute manner and you do not have time to do all these investigations or treatment cultures and all which you have told. So what will be your
We should
treatment?
keep keen observation. If usually we start steroids. So if there is a deterioration of the cases, we should stop steroid immediately. Then we should wait for microbiological evaluation.
So what we are trying to ask is basically, would you like to do a swab, like by default, what is the protocol in your OPD if a patient lands up with a scleritis? Would you like to do swabs in every case, or directly go ahead with the treatment and then see if clinically it's worsening and then do swabs? That is question number one.
First, we should start microbiological means antibiotic treatment. We should start.
In all patients
But
by
in
default?
for steroid, we should take precautions. In all cases, antimicrobial treatment should be started.
So would you like to give some pointers as to differentiate between infectious and non-infectious scleritis,
Yes,
so that
this is
we could actually streamline our management accordingly?
That's why I add this slide which I
Yeah.
list. So comprehensive microbiological workup is essential. Empirical antimicrobial coverage if infection suspected. Surgical debridement of necrotic tissue if progressing. Scleral thinning is progressing. Scleral reinforcement like page graft, amniotic membrane if thinning is present. Immunosuppression only after ruling out the infection in these cases. And cautious topical steroid introduction after infection control.
So I think these are very important points,
Yes.
and the sequence is also nearly what I am okay with, except point number 5. Why? Because most of the times, even if it is an infective pathology, there is an inflammation which is there with the infection. So I personally feel that there should be an immunosuppression, or you can say better, it's anti-inflammatory. Could it be in the form of steroids with an antimicrobial coverage? So you have to be ensured that the antimicrobials are given properly in a proper dose. But at the same time, after a dose or two, you should be starting anti-inflammatory. Otherwise, they won't, get that benefit. Same are the cases for endophthalmitis, panophthalmitis, and many other infective pathologies of the orbit, cellulitis and all. Most of our colleagues, they give antibiotics, but they refrain from giving the steroids, and that is the reason their inflammation doesn't subside. Right? Thank you very much.